Assalamu alaikum, everyone. Welcome to another edition of Zoom In on the Halal Metropolis. We're checking in on the Muslim community and seeing how people are adjusting and adapting to the new reality under the coronavirus and the stay-at-home order. Here with me today, we have Dr. Hasan Shanawani. He's a pulmonologist and the medical director for clinical performance improvement at Blue Cross Blue Shield of Michigan, and also an attending physician at the VA in Detroit. Welcome, Hasan.
Hey, good afternoon. Salam, Razi.
Walaikum assalam. Good to have you here. So I want to get into some of your work and how things have been adjusting at the hospital and everything. But first of all, I want to check in on you and see how you're doing and how your family's doing under all this.
So, alhamdulillah, I mean, my wife is a gynecologist. She's at University of Michigan. I should, by the way, quick correction. I'm no longer at the Detroit VA. I'm actually at the TeleICU VA in Cincinnati. So I work here, but the VA runs a hub where we can do sort of remote ICU services all over the country.
Okay.
So I'm not working at the Detroit one anymore. I'm actually working at the national one, and it's based in Cincinnati. They're opening up a hub in Ann Arbor. We can talk about that in a little bit. Back to your question, things are going well. I will tell you, we're going to talk about a lot of things, but this weekend was actually what made the whole pandemic issue real for me, which is my oldest daughter, alhamdulillah, was an undergraduate at University of Michigan. Yesterday was supposed to be graduation, and it got canceled. And we didn't really think about like what we could do as an alternative. And yesterday we sort of found ourselves in this situation, sort of just thinking to ourselves, wow, this would have been awesome, putting on the cap and gown and maybe taking some pictures or something like that. But that was interesting, the work as an ICU doctor that I've been doing, and I've been doing a lot, the work that I'm doing with insurance. I also work for the American Muslim Health Professionals Association, the national organization. I'm part of the national task force for COVID. All of that, none of it made it feel real until yesterday, funnily enough. And that was the first time. And so this particular weekend's a tough weekend, but otherwise, alhamdulillah, we're doing well. We're all getting along. My two kids are at University of Michigan. One, obviously just graduated. They're doing well. Michigan's done a pretty good job of moving everything to telehealth. Michigan Medicine, where my wife works, is moving a lot of their appointments. And, just we're evolving. We're also, alhamdulillah, thank God, we're both in the medical profession, and I guess a silver lining to the cloud is that we both have jobs and we're both able to get paid. And we're looking at a lot of our friends and peers that are not able to work and thinking about everything, gym memberships, restaurants, all of the different services. We've been relatively spared financially. So all things considered, things are okay. I have not had to go physically work in the COVID hot zones. I've done a lot of remote work, and so I've been relatively avoiding the dangers as well. So there was 1 week where I did do some clinical work, and I had some exposures to COVID patients. And my in-laws have a basement. They have a little bedroom in the basement, and I had to live there for 14 days, self-isolated. And I'm sitting in there right now, in fact, as we're doing this interview.
Oh,
Not for isolation reasons, but
well, that's a beautiful basement. So you're lucky.
Yeah, I'm not complaining.
Yeah. So how does that work with you doing telemedicine for ICU work? Can you just walk us through that a little bit?
Yeah, so there's different models. I work for two different companies. One, obviously, like for the VA, and that one's a very sophisticated one. They're both very sophisticated. That one provides a lot of different services. The one that I do the bigger work for is a private organization, Sound Physicians, where I can do it from home. And I sit there on a computer like I am right now. And we have something that's basically Zoom on steroids. And I'm able to pull up the chart, and I'm able to look at x-rays. The nurses have a computer that they can take into the room, and I can look at patients with them. Normally, it's pretty low-key work. There's maybe 3 or 4 calls a night. You do some consults. It'll be busy, not because any one hospital is busy, but what we do is, these are all small hospitals that can't afford a full-time ICU doctor like me. They don't have enough ICU volume to justify a full-time physician, but they don't want to have to ship these patients miles away to a big university hospital. So to
Mm.
help them keep it, what we do is basically provide consult services, and they'll call me through this, basically a big app, and I log in. They take me into the room. I can look at the patient. I can basically do everything except touch them, and the things that need to do to touch. But I can look at the monitors. I can look at the ventilator. I can do some stuff, and then I basically provide work just like I'm a regular on-call doctor. What's
Mm.
made it different now is most of the hospitals that we started in the last few months are all on the East Coast. A few of them have been in the New York hot zones,
Mm.
and those hospitals have been overwhelming.
Mm.
Even for me, sitting here in the comfort of my house, it's nonstop work, and then your heart just starts going out to these people that are sitting there, because you're sitting there sort of bearing witness to, it's almost like watching the hurricane or the tsunami hit the shores on TV, and your heart sinks into your stomach. You feel sick. And I've had a couple times where literally physicians or nurses who are there, they're just crying. They're just on their
Mm.
knees. And I just thank God that I'm not there physically, but at the same time, it can get pretty overwhelming. And even, you would think to yourself, oh, this isn't easy work, this is easy work and that kind of thing. But honestly, last couple shifts that I've done, I don't sleep.
Mm.
My shift starts at 7 p.m. It starts at 7 a.m. And it's made
Mm.
it even more challenging now during Ramadan, because usually at the end of the shift, just so that you can stay awake, you slip down a nice big thing of coffee, and you
Yeah.
get your big sort of like Denny's breakfast, and that's not happening. Because
Yeah, right. Yeah, because the
you know,
timing. Yeah.
yeah, because it's and those of us, we've all worked in the hospital during Ramadan. We're
Mm.
used to that. That's not unique to telehealth, but it certainly makes it difficult when you really are having a difficult shift and you're just going nonstop, patient to patient to patient, room to room to room.
Mm. And so, just on a more even fundamental level, just so people can understand, kind of what's happening with this. What is the relationship between the virus and lungs, and what's happening, when people are being infected?
So, so the short answer, Razi, is we don't know yet. I mean, at
Mm.
first, this looked like a really bad what's called viral pneumonia or viral pneumonitis, very
Mm.
similar to what we take care of every day. The lungs will fail due to something called acute lung injury. The lungs are supposed to be these nice sponges that soak in oxygen and then absorb it and then push it out into the bloodstream. And so any problems with the lungs, that diffusion of the oxygen into the blood, the bubbling it, if you will, into the blood, makes it impossible for you to get oxygen. And then what the ventilators do is they keep the lung inflated so that that air exchange can occur. And the lungs have two jobs. They get good air and oxygen. And then by moving, they help your body get rid of CO2, which is the waste gas that your body makes just by staying alive. So
Mm.
both of those begin to fail. What we first saw was, of course, really severe, what's known as ALI, acute lung injury, or ARDS, acute respiratory distress syndrome, which is just the lungs start filling with fluid, water and pus and blood, and they don't move the air,
Mm.
and so they don't work. And then the ventilator just keeps you alive. It doesn't cure anything, but it keeps you alive while your body heals. And sometimes that takes 2 days, and for some patients, it can take 2 to 3 weeks. What then the other, so that's what we first saw. But then what we also began to see is that the blood, your blood starts to congeal. It starts to clot with the COVID infection.
Mm.
This is a new thing that we've seen before. We've just never seen it to this level. And the blood and you get millions of these mini clots in your lung. You hear them called clots or pulmonary emboli or PEs. And usually you get these big PEs, and we just put you on blood thinners, and you survive them. And sometimes we have to give you clot busting drugs, the same ones we give to people with heart attacks or strokes. That hasn't worked well with these patients. And that's been really kind of scary, because we're seeing these patients. And so and so it's interesting. We see the ventilators doing its job, but they're still not getting oxygen. And it's
Hmm.
because the arteries and the veins that go through the lungs to get the oxygen, they're not working because of all of these mini clots. And
Hmm.
that's been terrifying because it's not something that we've seen before, certainly not on this level.
Yeah. Yeah, it seems like from what you're describing, it's like a system-wide failure. You know,
Absolutely.
it's not just in the lungs. So based on what you're seeing and the treatments that you're providing, what seems to be effective right now, or is it just kind of a mixed bag of different types of treatments?
So there are individual stories, anecdotes of individual treatments that work on the blood clotting system, the immune system that shuts it down, because it is the immune system going crazy in the body and going haywire. And so there are anecdotes. There are some new drugs. Tocilizumab is this new experimental drug. There is a virus medicine, remdesivir, that we believe might be working. Again, to know if these drugs are going to work, you have to try them on 1,000, 10,000 patients, and you want to do it in a systematic way. And we are only in a normal situation, those things take 6 months, a year, 5 years to
Hmm.
get those studies to work. We're trying to get those studies up and running, started, get patients in and complete them all in the span of 3 months. And that just, the logistics of doing that become really difficult. And so what ends up happening is you see all these mini trials and everyone's so desperate for knowledge. What we're
Wow.
seeing, it's actually caused a lot of stress on the way we even share knowledge as doctors. The journals have published articles that under normal circumstances would never rise to the quality, the editorial quality of a journal. And JAMA went through a big thing just last week where they published an article and then they kind of retracted it 3 days later, which I've never seen that in my career as a doctor, that they published an article and less than a week later, they pull it back because they realized that the quality of it was so poor. Even in the institutions, those things that we've grown to trust,
Hmm.
heavyweight journals, um, they're you're not getting the information that you trust. And so
Hmm.
people just start throwing stuff out. And what's actually the other interesting thing is on Twitter and on Facebook, there are chat groups now of doctors that are sort of comparing notes and throwing stuff out there. And that has become honestly my best source of knowledge right now
Interesting.
is Twitter. I'm
Yeah.
getting more reliable scientific information from experts in the field that normally I would never have a conversation with. These are giants in the field, and they're talking about it, and they throw stuff out there, and then everyone sort of goes after them, and they're able to. And honestly, if their stuff survives the court of public scrutiny on Twitter or Facebook, then you can say, oh, that might be reliable therapy. And so and that's not that's not the first time that we've had that. Pentamidine back in the late 80s and 90s was a drug that we used in HIV, and it was only through active lobbying from advocacy groups of patients that were getting a lot of HIV and AIDS that finally the medical community said, okay, we'll give this a try. So sometimes this grassroots things happen. I've just never seen it personally in my own
Hmm.
career in real time like this. So it would be exciting and cool were it not so terrifying, like the circumstances under which we're so desperate for
Hmm.
knowledge. Unfortunately, we've also seen a lot of bad therapies. I mean, the stuff that you're hearing about
Yeah.
with Plaquenil. I mean, the Plaquenil is what's known as a quinine therapy. We
Hmm.
still use it in malaria. It's been used
Hmm.
for decades. It's 100 years old. It's not a new therapy, right? We
Hmm.
know that quinine suppresses your immune system, and we still use it in lupus and rheumatoid arthritis, and we use it as a drug in malaria in Africa and Asia and stuff like that. So it's not a new drug, and it costs pennies, but they were desperate. They threw it at patients. It looked like it made a difference, and so everyone's like, "Oh, you got to give that drug." Turns out it's not so great, and it's a toxic drug. I mean, quinine's poison, right? I mean, it's
Oof.
literally it's
Yeah.
literally a toxic agent, and so it's a heavy metal, and that's the
Hmm.
reason why it's effective in malaria, because it's a metal. It kills living tissue, including the
Hmm.
ones in your body.
Another question I know that you're probably getting a lot right now is who are the folks, in the community that are most vulnerable to this right now?
So, so I don't know the details epidemiologically, and I would want to go to the the original sources. Let me tell
Hmm.
you what I know from some of the big studies that I've read.
Hmm.
I don't know what the hit rate is, but we know that if you get COVID, you have a 20% chance of being sick enough that you need to be admitted into the hospital. So 1 in 5. And out of that, so let's take 100 patients that get COVID, God forbid. 20 of them will need to go into the hospital. Of those 20, 5 to 10 of them will be so sick that they need to be on life support, need in
Hmm.
the ICU, and need either super high doses of oxygen or to go on the ventilator just to stay alive. Um, what's interesting, so what, of course, we know, and this is not unique to COVID, everybody in the ICU, 20-year-olds with no health problems do much better than 80-year-olds with a lot of health problems. As you get older, at the end of the day, we don't cure disease in the ICU. What we do is keep you alive while our colleagues, the surgeons, the infection doctors, the cardiologists, we fix other doctors' fixings. We are in the business of keeping you alive, keeping you support. We keep your heart pumping with adrenaline drugs known as pressors. We keep your lungs moving using a breathing machine known as a ventilator. We stick a tube in your nose that goes to your stomach and feed your gut, and we hook you up to a machine that works your kidneys and dialyze you. But we don't cure disease. At the
Hmm.
end of the day, your ability to survive the ICU is less dependent on the good care that's being delivered by doctors and nurses, although it's absolutely dependent on good care. But it's less dependent on them and your body's ability to bounce back and heal. And we know that 20-year-olds heal better than 80-year-olds. And so as you get older, you're less likely to heal. The more medical problems you have, diabetes,
Hmm.
heart disease, stroke, cancer, immune system problems, again, the less likely your body is to heal.
Hmm.
Sadly, what we're seeing though is that people that we would never expect to have any problems are having major problems. So under the age of 40, they're not necessarily dying from like the bleed from breathing problems. They're dying from these massive blood clots that we talked about. I mean, I've seen 30-year-olds having huge strokes because the blood clotting issue is a systems issue and it's happening
Yep.
everywhere. So they don't
Hmm.
just have the clots in their lungs, they have the clots in the heart, and then you have a heart attack. They have a clot in their brain, you have a stroke. So we're seeing these massive uh, problems all over the body. Um, it, it, your survival rate is a little better if you go on life support, but
Hmm.
it's only a little better and it's
Hmm.
still pretty severe. The death rate, depending on where you look at, if you go on life support, I don't want to quote the numbers. I certainly don't want to make them up. I've heard numbers anywhere from 40%, which is what we normally see, as high as 80%. It's
Hmm.
terrifying. It's really, uh, and it's not just that the numbers are so bad. It's just that so many, a big fraction of a big number becomes a big number. You know,
Yeah.
it's one thing when you have a 20% death rate and you have 5 patients. It's another thing when you have a 20% death rate and you have 50 or 500 or 5,000. That's when
Hmm.
it gets absolutely. It's just what's so scary about the coronavirus thing is everyone's quoting these numbers. The attack rate of this virus is immense. We're just
Hmm.
that's why everyone's so scared and everyone's recommending the stay at home and the social distancing because
Yeah.
it seems to be so easy to pick this disease up.
Yeah, and speaking of social distancing, it seems like okay, on an individual level, that's the most one can do, is to practice social distancing, wear face masks, wear gloves, wash your hands, and I think it's a pretty simple formula to follow.
Absolutely.
Now, those that are sick, but they're not sick enough to go to the hospital, how what are the best ways to treat this at home? Let's say God forbid I get sick, or and I live by myself, and so what would you recommend in that situation?
I mean, the basics, good nutrition, good hygiene, and staying away, of course, from other people if you have the infection, but
Yeah.
getting your sleep, eating right, that kind of thing. Some of the tricks, and again, I'm not giving official medical advice over an interview, but I guess the most important advice I can give you is let your body be your guide. If
Mm.
you get to a point where you're struggling to breathe, you just need to get to a hospital. And the reason why is because you can go from not being able to breathe to needing to be on life support and not being able to survive without it within 6 hours. So it's not the
Oof.
kind of
Wow.
thing where you can just stay at home overnight and be like, well, I'm getting a little chest tightness, let me just see how it goes. You need to keep in touch with the medical system, with your doctor, or with your local ER, and let them evaluate you. The best advice I can give you is, and if you're doing well, you're doing well. People
Mm.
can turn on a dime for the worse, but like I said, let your body tell you how it's doing. It'll be your guide. Trust me. The dumbest lungs are still better than the smartest doctor. Here, if you can't breathe, your body's not doing well. You don't
Mm.
need me to tell you that.
Mm. Yeah, wow. Well, Hassan, thank you so much for your time. I really appreciate it. Glad to see that you're doing well, and really appreciate all the work that you're doing remotely, but also on the front lines at the same time. Please keep it up, and we really need people like yourself out there. And thank you so much, and stay safe.
Yeah, my best to your listeners, and Ramadan Mubarak, and my best to the healthcare workers, the ones that I'm serving as they serve the patients at their bedside. Thanks again for this chance.
Assalamu alaikum.
Alaikum salam.